Professor Tekgul, thank you very much for your agreement to make an interview. And first of all, we'd like to ask you to introduce yourself to our listeners, some words about you, about your clinic, about your interest in urology.
It's certainly a great pleasure to be here. I am a professor of urology. It's been like 12 years now that I'm a professor of urology. I've been doing pediatric urology for more than now 20 years. I started doing only pediatric urology in 1991. This was after I got the certificate as a urologist. I started doing sole pediatric urology in my department. Then I worked like a pediatric urologist for 3 years. Following that, I went to States, to University of Washington. I worked with Mike Mitchell. I did fellowship with him for 2 years, and following that, I've been doing only pediatric urology. After coming back to Turkey, where I am now, I've started the Department of Pediatric Urology in 1995, and that department has been one of the leading departments of pediatric urology in the country. And actually, we become the first accredited training center in the country, and it was among the first 5 accredited training centers in Europe. And we have 15 sole pediatric urology beds, and we do about 1,000 pediatric urology operations a year. And we've been training fellows for the last now 17, 18 years now. So our main interest in our department, actually we do everything in pediatric urology, but since we're a referral clinic, we're receiving a lot of secondary cases, secondary hypospadias, very complex reconstruction of the external genitalia. We have a very big series of bladder reconstruction, which is mainly augmentation, and we do a lot of extirpations. And also, since pediatric stone disease is quite endemic in our country, we do a lot of pediatric stone patients as well. And I've been publishing a lot on pediatric stone disease, augmentation, reflux, almost everything. And what I also do internationally, I am the secretary of the ESPU for the last 3 years now. Before that, I worked as the chairman of the educational committee of the ESPU. I did the scientific secretariat of the ESPU. And apart from that, I've worked for EAU as well. I'm currently the chairman of the guidelines committee of EAU. I've been doing this since 2007, for now nearly 6 years. And also, I was also a member of the International Consultation for Continence of the World Health Organization, and I've been recently the chair of it, where we wrote the guidelines for childhood continence with my fellow doctors. What else do I do? I worked for ICCS. I organized many meetings. So my main interest in pediatric urology is probably, I would call it as complex reconstruction and pediatric stone disease.
And if we talk about the urological help to children, I think first of all we should talk about the organization of this medical help to children, and how do you think, how it's organized, for example, screening, urological screening in children in Turkey, and how it should be organized? Because what we trying to arrange it in Russia, and a lot of different laws and different things from different departments. So how do you think
it's also very complex and very confusing in Turkey? I don't think it's very well organized anywhere around the world. Maybe in a couple of places, maybe in the United States, and in some countries in Europe. I think pediatric urology should be considered as a subspecialty. And those people who qualify, who had additional qualification in pediatric urology, should be performing most of the pediatric urological cases. You can get additional training upon pediatric surgery or urology. But you should first be qualifying as a urologist or a pediatric surgeon before you really start doing pediatric urology cases, especially the majority of the cases. When you go around the country, it's probably the same in Turkey, you'll see many people are doing pediatric urology, although they're not well trained on the topic. And this is more common among pediatric surgeons, as pediatric urology is a major portion of pediatric surgical treatment. This is less in urology because urology has a much wider field where you can do oncology, prostate, bladder tumor, etc. Pediatric urology in urology is considered to be something more difficult to do and less attractive to do. So we do have, I think in urology, we do have more committed pediatric urologists than among pediatric surgeons. Pediatric surgeons, almost every pediatric surgeon is willing to do pediatric urology. No matter where you're coming from, I think the key is you should have some additional training in pediatric urology and then commit yourself to pediatric urology or confine all of your cases, or at least to start a majority of your cases in pediatric urology. If you're doing prostate surgery in the morning and some pediatric urology case in the afternoon, you will never become a pediatric urologist. You should do as much as possible pediatric urology, and then in time you'll become so busy with pediatric urology you won't be looking for anything else to do. I know it's challenging because doing reconstruction and doing congenital abnormalities is not easy, and compared to some other surgeries in urology, it's more challenging, but we need people who are committed to pediatric urology, and those people will help the advancement of pediatric urology in Europe, in your country, in my country, everywhere. So there's always a big fight among pediatric surgeons and urologists. Actually, we should be objective in that fight and say that anyone who's willing to do pediatric urology, who's able to commit himself to pediatric urology, should be considered as a pediatric urologist, no matter from which background he or she is coming from. So what additional training? I think this additional training, the criteria for this additional training has been well defined in Europe. Probably, you know, but I think most people would have heard about the JCPU, Joint Committee for Pediatric Urology. Joint Committee for Pediatric Urology is composed from people from the Board of Pediatric Surgery, from the European Board of Urology, and from ESPU. There are actually 6 people. 2 is coming from ESPU, 2 from Urology, Board of Urology, and 2 is coming from Board of Pediatric Surgery. Those people, this is a regulatory board which is composed in 2003, and that board decides the criteria for becoming a pediatric urologist, and it's well defined now. And according to that criteria, you need to be working in an accredited training center, and you should do training for at least 2 years, and during that 2 years, you should at least be doing 250 pediatric urology cases a year, which is a well-distributed case. I mean, you're not going to be doing 150 circumcisions, and you should be doing. Yeah, there's a good and it's also well-defined, and in accredited training centers. If I'm not mistaken, currently there's 17 accredited training centers in Europe now
for pediatric urology.
For pediatric urology. You can get them from our website. And though if you do training 2 years in those centers, then you get a qualification exam, which is usually run at the annual meeting. And this year we're going to have another one. And this year, for the first time, we're going to be having the oral exam. So basically, if you're trained, you get an exam, you get a certification exam. If you pass that exam, you get an oral exam, then you're qualified as a pediatric urologist. So far, the qualification has been mainly done on CVs. People have put on their CVs and applied for fellowship position. And I think the number is around 180. There are 180 certified pediatric urologists. But for the last 2 years, those people who have been trained will get the certificates. No other people will be able to do that. Okay. So I think the initial step for you in Russia is to start up some training programs and follow those criteria. I'm sure you have the expertise and the volume to run a training center. Once you start your training center, you can have fellows or trainees to work with. Then you can apply for accreditation, and if you fulfill the criteria for a training program, you'll be named as an accredited training program. Then you'll be producing new pediatric urologists in your country. But I think again the key is you should have committed people and those committed people should start the training program. You need only 2-3 people to start a training program.
Okay, I see. And how do you think, does all the pediatric urologists should be done by pediatric urologists? Or for example, the first step, for example, screening, or the first
I agree.
by pediatric?
No, this is not possible. Some of the things should be done, of course, with primary care patient or primary care urologist, I would say. Most of the penile stuff and the scrotal surgery will still be done by the general practitioner, general urologist, or general pediatric surgeon. There's no question about that. But I think if you follow the EAU guidelines, you'll see that there are points where we definitely very clearly define that case should be done by a pediatric urologist, like on a hypospadias case. For instance, hypospadias cases should be done by experienced people. We all know that. I mean, the common understanding that if somebody is not doing more than 50 cases a year, hypospadias surgery, it's not possible to get good results. But I mean, if you're doing orchidopexy, I think you should continue doing it, although you're not a pediatric urologist. But if you have committed people and committed centers, there will be less and less people in the periphery to do pediatric urology. They would prefer to send their cases to you. And you'll be able to accumulate more volume, and you'll be able to accumulate more experience in pediatric urology. This is especially true for complex reconstruction, complex abnormalities, reflux, UPJ, prenatal hydro cases. And all those cases should be accumulated in centers, and they should be trained by experienced people. And also they should serve the trainees for them to be able to learn the practice.
How do you think, do we need any screening programs for pediatric urology? And what age should we screen? Newborn?
Screening program. Actually, there have been a couple of screening programs around the world. I'm not sure if they are very good. One screening program, which I found quite interesting, was in Belgium, screening varicoceles. And actually, recently, you know, the person Guy Bogart, who was the previous secretary of ESPU before me, he reported that the screening has not given any good results in Belgium. So this has not been a very productive screening program. Well, I wouldn't call it as a screening, but nowadays almost every child who's before they're born, they're having a prenatal ultrasound. I think this is the best screening that is being done, not on intention, but this is regular practice. And I think screening prenatal hydro has some impact on the well-being of children. In my country, for instance, stone disease is quite endemic. It's like 1%. So screening couldn't be an idea in my country. But I think you should try to name the group of people or children who should be screened rather than screening everyone. You should define the age and the risk groups, then you may consider screening programs. But currently, I think screening is not a big, huge, attractive topic in pediatric urology. Not like in the adult, not like in the adult population. But I think without intention, we are screening most of them by prenatal ultrasonography.
So, and from the screening, can we move to basic research? And
sure,
I would like to ask you some words about the basic research. How do you think, what are the most important and perspective achievement in this field? For example, markers of obstruction, or any other new drugs for treatment? What do you think?
It's a huge field, and it's quite new in pediatric urology. Actually, it's just emerging. I did some work when I was a fellow on markers of obstruction, UPJ obstruction. Many people have looked at many different lysosomal enzymes with the idea that with the breakdown of renal tubular cells, lysosomal enzymes are coming out, and if you can find them in the urine, then it could serve as a marker. But none of them have shown a great value. So nowadays, I don't think anybody has been able to define a great marker for obstruction. So I don't know if there's any potential in that aspect. Still, I think the only definition of obstruction is by clinical terms, and it's just by serial screening or serial imaging of the patient. So biomarkers for obstruction have not been of much value, and I don't see a great potential in it, personally. And I think the main area would be still tissue engineering. Initially, it was very promising. The initial studies have made have created a lot of attraction, but it's not been possible in any way to carry it to clinical practice. Some initial reports have also shown that the practical value of tissue engineering has not been possible. But I think there's still some value in this work, and there should be more and more people investing their energy in tissue engineering. The main problem with the tissue engineering has been, although people have been able to proliferate the cells, the bladder cells, the detrusor cells, whatever the cells that they were putting in, they've not been able to create angiogenesis. So the continuity of proliferation have not been able to maintain, and plus the structure have not been able to maintain. And they try to use biocellular matrices, and that didn't work very well either. So this is still promising, but the clinical value is not there yet. What else? I think the most interesting or most attractive area is to work on genes and see if you can manipulate genes for the future, especially for hypospadias. If you can define the genes that are playing role in hypospadias or some other congenital abnormalities, and if you can define those genes, and we can maybe do some prenatal diagnosis by using the genes, or by manipulating the genes, maybe we can prevent some of the diseases. I think this is the main area for the future.
Okay, and so some questions regarding everyday practice for urologists. And first of all, about VUR as one of the most often seen pathology and one of the disease in children. I'm not going to ask you all about VUR and prognosis and comparison of endoscopic treatment, but some questions that are not answered. For example, what do you think about, is there any more difficulties for reimplantation of uterus reimplantation after endoscopic treatment? And for example, after Vantris or Deflux or collagen, is it differ?
Okay, I can give actually we've just writing a paper on that, and we will report that in ESPU meeting in Geneva. We looked at nearly 400 patients. And initially, when we looked at a group of our patients, we said having injection does not change the complication and the success rate of reimplantation. Yeah. But when we looked at a big group of patients, we've come to realize that there's a significant decrease in your success rate and an increase in your complications, depending on the number of injections that's been done, also the type of injection material. The non-biodegrading injection material, like Vantris, is causing a lot of reaction, local reaction. And the dissection of the ureter is much harder in this group of patients. And actually, we also ended up in losing the distal part of the ureter in some cases. So I don't think now, I cannot say that the results of reimplantation is as good as if it's injected or not. I think there's a bad impact on your reimplantation after injection. But the number of injections and the injection material is important, and we will report our results in the ESPU meeting. And I think one other issue is about injection. It's again coming to the previous discussion that we did about who should do pediatric urology. And many people, many urologists have shown interest in reflux because of presence of injection therapy. Everybody considers injection therapy an easy treatment to do, and everybody is willing to do that treatment. But we've seen so many cases have been treated without indication because injection therapy is there available, and it's easy to do by everyone. So we've created a lot of cases who shouldn't have been treated at all with reflux, and have become some cases that need some sort of surgery because of after injection. This is one major issue that needs to be considered actually. because of needless injection therapies, we are having a lot of patients that we need to treat on, and we need to reimplant the cases after that.
So can you give some basic rules? Don't do this. For example, don't do endoscopic treatment before 6 months, or don't do if there's no acute pyelonephritis, or what some basic rules don't treat those reflux.
Okay, it's not easy to make solid statements in reflux disease, because whenever you make a solid statement in reflux, there's going to be something you're missing. But I can tell you there is one clear contraindication for injection therapy, which is refluxing and obstructing megaureters. And those are the megaureters which have a narrowing distal end of the ureter, which are reflux and at the same time obstructed. And once you inject those patients, you'll be able to stop the reflux in most of the cases, but you'll be creating more obstruction and you'll actually be damaging the kidney. This is, although a small group of patients, I've seen a number of those patients who have been treated by injection therapy, and the patients have lost the kidney. So this is a major and clear contraindication. We know that injection therapy is not very good in high-grade reflux. I cannot say that you should never do injection therapy in high-grade reflux, but the success rate is around 50% per ureter with high-grade reflux. We never do surgery with 50% success rate.
Yes.
It's like tossing a coin. I mean, so I don't advise doing injection therapy for very high-grade reflux. What I would suggest for doing injection therapy is those patients with low-grade reflux who are actually good candidates for conservative treatment. You can consider injection therapy as an alternative to conservative treatment, because it's got a similar success rate with the conservative approach. If you follow the patient for 2 or 3 years, the success, the resolution rate would be around 7 to 80% for grade 2-3 reflux. You get the same result with a single injection therapy. So, but the good side of it is that you're going to be stopping the prophylaxis. And I think there's a good indication there. For all the other indications, I think it's okay, but it's a matter of choice. But personally, what I do, if the patient really needs a anti-reflux surgery and has reflux above grade 3, then I would do open surgery or a reimplantation.
Even the grade 3 you would?
Well, above grade 3.
Okay. And now
I also decide on looking at the orifice. When I do cystoscopy and I see that there's a golf wall orifice or a very short submucosal tunnel, I don't inject those people, I do reimplantation. Grade is not the only indicator, because grade is actually reflecting bladder function more than the anatomy. If you have high pressure bladders, you'll have high grade reflux. So grade is not the only marker or the only thing that should lead you to the decision of injection therapy. There are more things involved. But if the patient has got breakthrough infections, suffering from pyelonephritis, and really needs a anti-reflux surgery, most of the time I think the treatment of choice would be reimplantation.
Do we need more randomized controlled trial regarding VIOA?
Sure, yeah. I mean, the only one that is available, a good one, is the Swedish study.
Yes.
When you look at the Swedish study, although it does not compare injection therapy with open reimplantation, it compares it with conservative approach.
Yes.
It's been very clearly shown that injection therapy is not very good. The scar formation is higher compared to conservative treatment, and also the resolution of reflux seems high in the first 2 years, but after 2 years there is 20% recurrence. But the problem with reflux is that it depends on the population that you're studying. There are so many different populations, and reflux disease presents within a spectrum. If you're looking at a group of patients who are in the benign part of the spectrum, then injection therapy would give you good results, conservative treatment would give you good results. If you're looking at the group of patients on the far end of the spectrum, the bad group, then injection therapy will not give you good results, but open treatment will give you much better results, and the conservative treatment will not give you so good results.
Yes.
And I think Swedish reflux study had more of a bad group of patients than the benign group of patients.
And also some questions regarding hydronephrosis, and they most, I think, discussing problem about laparoscopy, robotic surgery. Is it used for pediatric urology? For example, recently I've been talking to in Davos with Professor Neyman, and he told me he sees no difference for laparoscopy, open surgery, because he scar for 4 centimeters or for 1 centimeter, he doesn't see any real difference. What is your opinion in this,
okay,
on this
there
topic?
are personal approaches, and everybody's biased on that. I do laparoscopy. In my practice, I do laparoscopy for nephrectomies, upper pole nephrectomies, and I do orchidopexies. This is routine. I always do laparoscopy for those. For UPJ, most of the patients that I operate on is below 2 years of age for UPJ. So I don't do laparoscopy, and I don't see any benefit of it. Because with, in a newborn or in a very young child, you can do the whole operation with a 3 centimeter incision with a very good success. So, but if you're dealing with older children, with the older child, like around 10, 11, 12 years of age, I think laparoscopy may have a value.
Yes.
But again, the advantage that it brings is not huge, or is not big enough to consider as a very good option. So I still do open surgery for UPJs. For reflux, I mean, it's a long story, but many people have tried doing reimplantations with laparoscopy and with robotic surgery. I know I'm not going to go through the history, but actually it's not a long history. It's been over the last decade. Those people who've started doing reimplantation intravesically with pneumovesicum have been a couple, and the number have not increased in time. It's always been those people who've done that surgery, who tried to make it popular, but it didn't have a wide acceptance among the pediatric urology group. So it didn't really bring great advantages. The patients had similar spasms. The postoperative complications have been quite similar. I mean, I do open reimplantation, and I keep the urethral catheter for 24 hours, and I can discharge the child the following day or in 2 days. It's the same with intravesical approach. The only thing is the incision length, as Professor Neyman said, I don't see a big advantage of it. I don't see any big advantage of having an incision 2 centimeters less, really. I think the main advantage of laparoscopy or robotic surgery have come into attraction when people have done it extravesically. I think there's a value there, and if you're able to do extravesical reimplantation, I think it's a good option. But again, in the young child, in the children below 4 years of age, this is not very easy, and it's not very feasible to do. And many people have reported that the pediatric pelvis, bony pelvis, is too small to do laparoscopic or robotic surgery below 4 years of age. There is a value there, but doing laparoscopically is more difficult than doing robotic now. I mean, when you're doing reconstruction, I think it's a rule in laparoscopy. You need to move to robots. With laparoscopic instruments, it's quite obvious that you have limited space and limited maneuvers. And I think in such complex, when you do reimplantation, I would consider it as a complex surgery, you would need a robot. If you're insisting on doing laparoscopic, you should be very experienced on it. Then you can have some good results. But I still don't do any laparoscopic surgery for reimplantation, as my results have been very good with open reimplantation, and the morbidity is so small. And the parents are not really asking you for less morbidity. They want a good treatment.
Good result.
And good results. And no minimal invasive therapy could bring you any better results than open surgery, because you're doing the same operation. And you're doing the same operation with more experience. You can only have the same result, probably with less success. So if it's not bringing you any better results, but maybe some comfort, which I don't see a big value in it, then it could be considered as an option. But I don't think it's a big option for reconstructive surgery yet in pediatric urology.
And regarding new technology in pediatric urology, as you do a lot of stone surgery, what do you think about the new technologies in endoscopic treatment, for example, microperc or iPad-assisted percutaneous surgery? Is it used? What of new technologies could be useful, even especially for pediatric stones?
I think as the size of the instrument is getting smaller, especially with the microperc, it is actually very attractive for pediatric cases, and also having better flexible instruments is also good for pediatric cases, especially when you're able to do retrograde intrarenal surgery. But again, the downside will be the cost. When you have big volume of patients and you have high technology, the cost is becoming bigger and bigger, and that's another big issue that you need to consider, especially when you're doing stone surgery, because when you're using flexible scopes and doing retrograde intrarenal surgery, you lose your scopes in time. I mean, you can use it in a limited number of times, then you start losing your vision and you need to change your scope. So there, I think it's good for better results, but then there is a big concern for the cost.
Professor Patel told also in his lecture that in 99 cases he does not need a flexible urethoscope for make retrograde surgery, and for example in pediatric.
Who said so?
Anu Patel.
Okay, that's an adult group though.
Yes, that's what I'm asking. In how many percent of children, for example, we need flexible instruments?
That's very difficult to say because we're not doing many retrograde intrarenal surgeries with semi-rigid scopes. You can go up to the level of UPJ in most of the cases, but once you go into the kidney, you're limited. You're limited only to the upper pole and the pelvic stones. So when you're there, you'll probably need more of the flexible scopes to do retrograde intrarenal surgery, especially for kids. And so I don't know how Anup is dealing with lower pole calyx stones when he has a rigid scope. He's probably not doing retrograde intrarenal surgery for those.
Probably, yes. And what do you think about X-ray shock lithotripsy?
Corporeal,
yes,
okay.
extracorporeal, yes.
Yeah, I think it's still the first line treatment for most stones, especially if the stone is less than 1 centimeter in size. And I think if you have a good instrument and if you know how to use it, and if you spend some time on it, in time what happened is that the doctors are not very attracted by the use of ESWL, and they've not been very meticulous in treating patients with ESWL, and they try to do more percutaneous surgery. And I think if you have a renal pelvis stone of less than 1 centimeter in size, I think the first line treatment for the still ESWL. I would consider ESWL as the second line treatment for a lower pole calyx stone. Then I would consider percutaneous better option for those. And for those stones above 1 centimeter in size, then the stone burden is too high for ESWL. But again, most of the stones in our group of patients, I think we're treating 60% of the patients with ESWL, because most of the time we have smaller size stones.
Do you do prophylaxis, metaphylaxis in children with stone disease?
Oh yeah, it's got a value. I think you should be using more prophylaxis, and the only one is for most of the calcium stones is this straight treatment. And we've shown and we've reported many results that we've been able to reduce the recurrence rate with the use of straight treatment, potassium straight treatment.
So you think it's
got a value, and I think it should be used. Yeah.
And who do this? Pediatric urologists, they do care about these patients? How is it organized?
We cooperate with the pediatric nephrologists doing that, but I mean, most of the time we are the people who are starting the prophylaxis. But sometimes you have some complex cases like renal tubular acidosis. Then we would consult the pediatric nephrologists. But if you don't see any major tubular abnormality, any major problem like cystinosis, then we would start prophylaxis in our group of patients and follow them.
Okay, so I have some questions about blood extrophy. It's
okay.
quite a rare anomaly, but anyway we see those children. And for example, in Turkey, how many bladder atrophy are diagnosed prenatally? If you know some numbers, for example.
No, I cannot give you that number. There are many patients being missed during prenatal ultrasonography. It's an easy one to diagnose. Actually, the only way to diagnose is that if you don't see the bladder on serial ultrasounds prenatally, then you should start thinking about exstrophy. But this is not very common. I mean, it's like 1 out of 40,000 births, and many ultrasonographists don't consider exstrophy as a common problem, so they miss it sometimes. So prenatal ultrasound screening for exstrophy, I don't think it's feasible, and still we do see many exstrophy patients. But what are we going to discuss with exstrophy? How are we going to treat them? They're different.
No, I
Okay.
think it's quite understandable how we should treat them. But probably you can give some main points. What the main point to achieve the good results? What to operate them in 2-3 days or?
Okay, it's a big discussion. I mean, you can have a group of the most experienced exstrophy surgeons, and they may have different ideas. I've been trained with Mike Mitchell. What I do is what he did, and he taught me, and I think I've seen very good results with him, and I have some good results. I do surgery as early as possible without osteotomy.
Mm-hmm.
And I do a single stage repair, a complete disassembly repair. I disassemble the bladder, urethra, the corpora, everything, and I put them back together in the first operation. I think this has given good results. The only downside of this operation that is too complex, and you may not end up in the male with a urethral meatus at the tip of the penis, and that may need a secondary surgery. But again, like almost every technique, this has got some complications, and you have to be able to deal with the complications, and you need to be experienced on that. I think the main point about the good results is that you need to have experience in exstrophy. This is why exstrophy patients should not be treated by every pediatric urologist. I'm not saying urologist, but every pediatric urologist, and there should be people who are experienced on that.
So
and in every country, there should be
centers.
1 center, 2 centers, whatever.
Okay, and of course some words about hypospadias is one of the most common. And what do you think, what do we need now in treatment of hypospadia? I don't think we need more operative techniques or whatever. I think what do we need? Some new classification or some basic rules for considering the complication rate. For example, today in the morning I saw a lecture and it was said that complication rate is really higher than
in the long run.
Yes, higher than we see in papers, about 25-27%. Then we see, for example, by sonography it's only 5%. So what do we need? Need more new classification or better clarifying the results or long-term results?
What you need is experience again. I mean, the hypospadia should be treated by experienced people, and should be treated by people who are able to define all components of the anatomy, like the glands, the urethral plate, the corpora, adjacent tissues, the dysplastic tissues. If you're able to define all those parts of the anatomy, then you'll be able to know how best to put them together and turn into a good penis. And I don't believe any classification system is defining the problem well enough, because I mean, we can both name 2 penises as distal hypospadias, but there may be a big difference between the 2, because the urethral plate may be wide in one, the groove it may be deep in the other, and that makes a big difference, although both are named as distal hypospadias. So when you look at the literature, actually, it's very difficult to define those differences by any classification method. So when you talk about distal hypospadias, actually you're talking about a benign group of hypospadias patients, but there may be some patients with very bad hypospadias, with severe dysplasia, etc. So actually you're not able to define that group of patients, because that definition is not there yet, or there should be some different definition of the tissue, etc. So when you look at the literature, there are varying results. And most of the time, no surgeon is willing to report their bad results.
Yes.
And so there's a lot of unreliability, I should say, in hypospadia surgery. And most of the time, what is really important is to be able to look at the long-term results. When those children operated early on, you need to see them later after puberty and how things are. And we get the results from adult surgeons, and we see that we didn't do well in the past. But again, the technique has changed over the years. It's been more than 10, 15 years. Over the last decade or so, we are doing a lot of good different surgery. So our technique is getting better and our results are getting better. But again, I agree that the complication rate is not anything less than 10%. It's much higher in the long run. So that takes us into another group of patients, what we call is the adolescent urology patients. This is becoming a very important field in pediatric urology now, where, I mean, there should be some urologists or adult urologists who are dealing with those patients who have been treated early on, and they come to adult age with many complications, and they still need some treatment and care. We need a group of patients, a group of doctors who are able to deal with that group of patients. And that transition from childhood to adulthood is difficult, and it's sometimes not possible in many health systems. For instance, you're working in a urology department, you're probably seeing both children and adults.
Yes.
There you don't have a problem. But in pediatric surgery, for instance, when all the children are being treated in a children's hospital, when they grow old, they don't know where to go. And the adult urologists are not very much willing to take care of those patients. So I'm also lucky because I'm able to follow all my patients into adulthood, and I do surgery when they are adults. So that transition, especially if these doctors are coming from pediatric surgery, is becoming important. And we've come to a stage now where we need to define adolescent urology and those people who should be dealing with this group of patients. And actually, I'll be going into a meeting in a half an hour about how we should define adolescent urology within EAU, because this should be linked to adult urology.
Yes, of course. And regarding the for EAU meeting, I understand it just began today, but I think you look through the abstracts and what is and process for the sections of pediatric urology.
This
here.
meeting?
Yes.
Yes.
And probably you can name some most interesting things you mentioned. For example, the most interesting abstracts or posters. What do you like best of what was presented for the meeting?
Okay, I didn't look at everything yet. I'm just sharing one. I just looked at those, and I have some papers there, so I would be biased. And actually, my poster has been elected as the best poster, so maybe I should not answer that question. But again, what I should say is that during EAU meeting, you don't see the best abstracts. We do see the good abstracts in ESPU meetings or the American Academy of Pediatrics meetings. I've been reviewing pediatric papers in EAU for a long time now. All I can say is that the quality is increasing. The quality and interest is increasing among urologists. But I can say that there's more interest in injection therapy than anything else. It's because almost everyone is interested in injecting ureters in urology.
And what do you think the most interesting for? What was the most interesting for you personally?
Okay, well, we can go together. That's a good one, which is coming from Egypt, looking at the long-term results of exstrophy repair in female patients. And this was a good group of patients, and I think that's a good one to look at. And I think we should be in pediatric urology, we should be looking at more long-term results. I think that's a good one. There are like 4 or 5 injection therapy papers. They're all okay. There's laparoscopic varicocelectomy paper, and there's also another laparoscopy for Wilms tumor. So those are the papers in my session. There are like 10, 11 papers, and I'm going to report a new technique for Mitrofanov when you don't have an appendix. This is a sort of an alternative to Monty repair, where we do again use the ileum, but we use the ileum where the part of the ileum that we use augmentation. So this is the paper that I will be presenting. I think these are all okay, but I don't see anything really emerging or becoming, really interesting significantly.
I think the ESPU meeting is going to be much more interesting.
In ESPU meeting, yeah, we will have some good papers. I know the papers. There will be about 140 papers which will represent. Again, I tell you, there are many long-term results being presented in ESPU, which I like a lot. There will be some injection papers again, which will be presented, and there's a lot of basic research papers, really good ones, which will be presented. And I'm hoping that you will all be there, and expecting more Russian pediatric urologists attending ESPU meetings.
And regarding Russian urologists, what kind of advices, for example, can you give to Russian pediatric urologists to improve urological care in Russia?
Well, I don't know if I'm entitled or I can give such an advice. I have no idea about Russian pediatric urology, what you do and how many people. I know there are like 15 Russian pediatric urologists who are members of ESPU, if I'm not mistaken, no more than that. I think there should be more people who are committed to pediatric urology. I think this is the only one that I can say. And I think more Russian pediatric urologists should go abroad, anywhere around the world, to increase their experience and bring that experience into their home country and start pediatric urology training programs.
And does ESPU provide any scholarship?
Yes, of course. We have visiting scholarship programs for 3 months. All you need to do, you apply preferably a training center, and you communicate with the head of the center, and we can give you a travel scholarship for the maximum is about 2,500 euros for 3 months.
For example, your center.
Sorry?
For example, your center.
Yeah, I mean any center.
Okay.
All you need to do, you write to the center, you get an acceptance from the center, then you apply ESPU, and on the website you can get the application form. You need to let us know what you're planning to do, what kind of training you had, what your ambition is, and the cost. You should be less than 40 years of age to do that, though.
Okay. So I think you're very welcome to Moscow in a month.
Oh yeah, I'm very much looking forward to it.